I'm an FMS. I'm from Johor Bahru, and joining us for this session will be Dr. Farah. She's an FMS from Sabah. Maybe Farah, you want to?
Hi, afternoon, Dr. Pan. Can you hear me?
Yeah, I can hear you. Yes,
Oh,
yes.
yeah, hi.
Okay, right.
Yeah, hi.
Okay, okay, hi.
I'm Farah Hamdan. I'm Dr. Paran's co-worker for Module 5. I'm based in Klinik Kesihatan Penampang in Sabah.
Okay, thank you, Farah. So basically, that's how we will do it for this afternoon. The first part, I will present the lecture on this health promotion, disease prevention. And then on the second part, there will be some group exercises, which will be done by Dr. Farah. Yeah, she'll be assisting me, and she'll come back around maybe around 3 p.m. onwards. Yeah, to brief you all on the next session. Yeah, so I will start with my lecture first. So I'm by the way, I'm from Klik Setan Mamudia from Johor Bahru. I was in Ipoh for the almost past 20 years, and I was recently transferred here last year. And I've been working together with Farah in Perak then, yeah. But now both of us are in different states. So welcome again, everyone. I will attach my slides here. Okay, all right. Good. So this is my talk today. It's on a few different components. One is on occupational medicine, and also include parts on health promotion and disease prevention. Yeah, and also in this talk there'll be some certification in occupational health. There'll be parts on environmental medicine and also on tribal medicine. Yeah? So this how roughly it's broken up, about 30 minutes each component, but it won't be exactly as such because we have a group exercises as well. But basically, this to show that these are the components in my lecture. Yeah, and so most of you are quite familiar with the other modules where you have organ centered modules. For example, cardiology, respiratory, abdomen, and so on. But this module is a bit different. It's a bit of a mix of a few different components, not organ based. So it will be slightly different. But I find many of the students, when they complete, they've kind of forgotten, right, this component. Okay. But it is equally important because it's part of your exam as well. You'll have single best answers and other questions based on this module, plus your assignments, of course, within your GCFM. Huh? So, how do we learn? The many ways we can learn, right? Especially for this module, we can access certain knowledge base, for example, textbooks, journals, papers, internet as well, and nowadays, of course, AI even help you to search for knowledge. And then we have learning systems of researching, which we'll all do later. I think probably when you start your ATFM. And then you can also discuss with your peers and tutors and colleagues. Of course, physical session will be much better. I can interact with you all online. I mean, physically, but virtual is slightly different. I hope all of you are engaged virtually and not just, on your PC and go away, yeah, right? And so that we can have a more interactive session. And then, of course, you're supposed to apply this knowledge in your practice and in your own practice. We're supposed to do an audit, yeah. And these are the systems of learning. Topmost will be cognitive, basically what you remember, what you see, you hear, you feel or you touch, and so on, and what you and the knowledge that you retain, right, from your perception, and this is a cognition. Yeah? Whatever you remember, and you can apply. There's also an emotive component to learning, where things that you like, you may remember better, or certain things that you may not dislike, okay, you also may remember better, yeah, compared to those without any emotional component, yeah. So if you tend to like your subjects or your tutor or your teachers, you may remember better, yeah. And similarly, if you dislike a certain subject very much, it can also have a strong impression on you. And the other one is psychomotor, where you do practical sessions, for example, setting granulas, setting drips, doing toilet sutures, maybe putting on plasters. And now in clinics, we also insert IUCDs, implant-ons, those kind of procedures. So these are the psychomotor ways of learning. Usually, we will have another senior or a mentor, yeah, who will demonstrate to you how to do these procedures, and then we try to copy them and then become proficient in these procedures, right? Usually, it's more difficult to learn from textbooks, this kind of procedures, because it's a practical session. Yeah. Of course, nowadays there are also video tutorials which we can use when there is no other seniors or what do you call your colleagues to assist you or to teach you. Yeah. But of course, the best is having the patient to do it. No? But in some instances, it may be helpful because live patients may not be suitable for certain procedures. For example, intimate procedures may not get a live patient to practice. So nowadays they use models, right? For example, in doing VEs, they have models doing pap smears and all that, or doing certain scans like ultrasound, vaginal scan may uh, may go for models because it's kind of difficult to get a real patient for these intimate examinations. And so, by adopting this new information, that's how we learn. And of course, we need to acknowledge your source of material. Make sure it's what do you call a proper source. Um what do you call an accepted or a body or regulatory body or what do you call reputable journal or source from the internet, because nowadays there are also a lot of knowledge out there, but many of it may not be correct, or, even false, or even fake, yeah, or even dangerous, yeah. So we need to make sure that we access the correct, the registered, an accepted or accredited source of our knowledge materials. And there are also many ways to retrieve these methods of knowledge in a systematic way for those who are involved in clinical practice guidelines, developing CPGs. We have the systematic retrieval methods, right? Um, and so we adopt this knowledge that we learn, and then we convert into our practice for decision making, and we apply the skills as well, learning into skills and skills in practice. So, what are the specific learning objectives of Module 5? Can you name them? Okay, I will just go on straight. Huh? So, overall learning objectives for this module is still quite basic actually. You need to be familiar with the primary care profile. We are primary care based. We're not secondary or tertiary referrals. So that's a difference between the hospitals and clinic setting. And we should be able to identify the common problems in our workplace and the solutions to these problems. And we have methods of continuous care for our patients. Yeah. And these are the specific learning objectives. Some of it may be quite basic, as in medical school setting, but it is still very important as a good family physician, that the foundation is solid. Yeah, you have a good grasp of your foundation before you go on to the further levels. For example, your clinical examination skills should be fine-tuned. Yeah, should be perfected, and should be very familiar and well versed with it. Yeah? Like cardiology, respiratory, abdominal neurology, for example, be very good at it. We should also be good in taking consent, how to elicit demographic history of this patient, and elicit all the other parts of a good history, such as past medical, family history, personal, psychosocial, and so on. Yeah? And then on, we should be familiar with doing the proper investigations and how to interpret them correctly. And then going on to the differential diagnosis. This is somewhat medical student level, but then on, as a good family physician, we should go on further. Like, what is the impact of the diagnosis on the patient? Yeah, that's further level. Yeah? And we also should be familiar on recognizing emergencies and how to triage them and when to admit which patients that deserve admission. Developing long-term care plans such as domiciliary patients, palliative care, those who need home care, nursing, and so on. Counseling skills, I don't think it's being taught as a specific module here, but we should all have some basic counseling skills when we see patients, right? Of course, some of you may have counselors in clinic. Some clinics do not have counselors at all. Yeah? So we do need to have some basic counseling skills as well as family physicians, knowing when to refer when it's beyond our scope, okay? Knowing which is our aspect or area to treat and when to refer accordingly, how to do self audits and dealing with families. So some of these specific learning objectives will be looked into during our group exercises because there are just too many of them, and we can't go on specifically on each. Yeah? So a better way will be to do group exercises, and some of you may deal with these some specific learning objectives during your group exercises. So let me go on to the next. Okay, I'm coming on to the main part of this lecture. So the first part is on health promotion. I'm sure all of you are familiar with health promotion. So there is, of course, a primary prevention aspect in health promotion. I will go on to talk about primary, secondary, and tertiary uh, prevention and what are the differences in a short while. So we will look into how to promote healthy lifestyle, and that will, of course, include dietary measures. Okay, just like as in having counselors, some of you may have dietitians in your clinic, right? But then not all patients can be seen by them. So we need to have some basic skills and knowledge on dietary counseling. And we call it medical nutrition therapy because we relate it to the disease. Okay. And next will be exercise as well, which we also call as therapeutic lifestyle changes. Okay. So in your module, if you go through the materials that I've given to you all, so you'll have the dietary, what you call guidelines of Malaysia, which will also include the exercise guidelines. So you'll have the pyramids, the dietary and exercise pyramids. And then we need some skills and knowledge on advising patients on how to avoid risky behaviors, improving intake of suitable health foods, and cultivating good family culture and mental health. And we all know that prevention is better than cure, isn't it? It's cheaper and very much practical and applicable to everyone. Yeah? In many aspects of life, in certainly in medicine, and definitely in disease prevention. Yeah? Right. And who said this actually? It was actually first mentioned by this person, called Desiderius Erasmus in the, I think, 15th century. Okay, that's a long time ago. So they understood and valued, prevention, because many things couldn't be cured even then. Even now as well, not everything can be cured. Okay. So coming on to primary prevention. What's exactly primary prevention? It starts before you are diagnosed with a disease. So it's basically you prevent something before you get a disease. That is primary prevention. So there is aspects for the whole community. You want to have it as a general health promotion for the whole community as far as possible. So you want to delay the onset or even avoid the disease. So this will of course include the promotion of healthy lifestyle, modifying high risk behaviors, okay, and definitely achieving and maintaining ideal body weight, which is also a big issue nowadays, right? Because it's one of the major risk factors to developing a lot of diseases. And of course, we want to improve the quality of life, right? And so let's look at some of the examples we have. I will take on the example from Australia because the government realized, okay, the importance of primary prevention. And they also realize that the best time to start is in childhood, okay? Early childhood. That's the best start to life. And then going on to schooling as well. And that's the best time they learn for life. Yeah? If you have good habits, you maintain it throughout their life. Okay? And if they establish a good foundation, they may have a good, healthy outcome and they maintain lifelong health. And not forgetting economic participation. These countries realize that a good economy is also very important. We find that many poor communities, they do not have health as their priority because the time is spent, you know, on finance, on earning, on getting, a salary and so on, just to, in some ways, just to survive, okay, to feed and to have a house, yeah, a roof above their head. So if they're wealthy, then they start focusing on their health as well. So economic participation of the whole community is very important. Healthy homes, that's another important thing, right? A healthy home and a a family is very important, yeah, to develop good habits as well. And what about communities? A safe and a good supportive community is very important. In this aspect, I will give example of Singapore. They invest a lot on housing communities where they support each other. And they have a good social cohesion among the neighbors, the community, and the different groups and communities out there. So they support each other. And all this depends on the government as well, the leadership, on their priorities to empower these communities. And it certainly depends on the local, Malaysian setting, the language, and our own culture here, right? And definitely the local bodies, councils. Okay, what are their plans? So going on in detail, what about children? Okay, specifically in fetuses or babies, it starts in utero. Okay, we even start prevention before the mothers get pregnant. They advise not to smoke, not to drink alcohol, to maintain a healthy diet, adequate exercise, rest and sleep, no heavy work. Okay? A healthy mother and a healthy baby. Okay? That's very important. We even start before they get pregnant. Okay? For example, anyone can give an example. One way to have a good outcome for the baby is the chat box. Okay, I can't see the chat box. Right. Okay, so any
Doctor,
example?
there's a answer in the chat box. Pre-pregnancy clinic.
Yeah, okay, yeah, now I can
For
see. Yeah,
yeah.
okay. So pre-pregnancy clinic is one. Yes, a lot of us are focusing on pre-pregnancy clinic. Yes, to ensure a good outcome. Of course, there is also focus on contraception there. For those who are planning to get pregnant, what's one good way to prevent or to ensure a good fetal outcome? Yes, folic acid. That's what I was waiting for. Yeah. Um, yeah, spacing, MDT for diabetes. Okay. Yeah. Okay. Some of you have given some answers there. Right. So, right. And once they are born, so these children, we go on to focus on good outcomes such as mental health, but that's a bit later. Body weight, definitely among toddlers, it's a big issue now. Therapeutic lifestyle changes, environment, and playtime, which is very, very important here because screen time has replaced a lot of physical playtime. Yeah. And that is the risk of this current generation, inadequate playtime and socializing with other kids. Okay, a lot of them are into screen time. Yeah. And then leading on to youth, teenagers, especially a risky period where a lot of them are exploring, experimenting, trying out new things. Okay. Uh, then they have a body image, self image, Some of them may want to try smoking, drinking. Okay. They have mental health issues, okay, with their peers and colleagues. A lot of comparison. Okay. And now with social media, there's also a lot of mental health issues when people start believing or start comparing, things out there in social media. Hormonal development. Okay, when they start having puberty, then there are a lot of physical changes, emotional changes as well. And of course, we need to talk about cleanliness, hygiene, and sexual health education as well in youth. In Before they are adolescent, from the years of 10 to 13 years old, is usually the time when they have self identity and autonomy. Before the age of 10 years old, a lot of children they identify with their parents. Okay, so the decision is made by the parents, the choices are made by the parents. When the identity, they think, yeah, an extension of their parents. Yeah, but from the age of 10 years onwards to about 13 years of age, it's just a rough guide. Okay, some may be earlier, some may be later. Okay, when they realize that they're separate. Okay, they are a different individual from their parents, and they have their own identity and autonomy. They have their own choice, what they want to do, what they want to eat, what kind of play they want to do, okay, or what kind of activity they want to do. They have a choice, okay, and then they start exerting themselves. Right. And this also reminds me of a patient that I saw some years back. So this girl was staying with a mother and a stepfather. Yeah, when she was about 11 years old, then she realized that she's an individual. She's no more part of the parents. And then she realized that she was sexually abused by the stepfather, right? And that's when she confided to the mother. The mother brought her to the clinic here to inform the medical staff. See, at that age, then they realize, that they are different, and they have autonomy, they have a choice, okay, and they don't like certain things that have been done without their consent. Okay, so that's when they realize. But younger to that, many of them are not aware. If they think, that they are part of the adult or whoever the caretaker is taking care of them. And then after the age of 13, from 14 to 17, that's the teenage years, the teenage angst. Okay, they have puberty there, and they start mixing around with their peer groups. Okay, a lot of grouping among their friends, but usually it's the same gender. So the boys started mixing around a lot more with their friends of the same gender, and the girls likewise. Okay, and the importance become more compared to the parents. Okay, previously they will idolize the parents, but now they start spend less time. Okay, and either contacting the parents or even idolizing the parents, and their peer group becomes more important. Okay, the opinions of the friends, okay, the ideas of the friends, and so on becomes more important to them. And then from the age of 18 onwards to about 21, the identity starts maturing, and then they are more confident, and then they also start to socialize with the opposite sex, and they start experimenting. Yeah. So this is the time they become more comfortable to socialize with the opposite sex. Okay. Some of them may start dating, okay, may start going out, and so on. Right. This is the rough development of adolescent. Yeah. Of course, the age range may differ with different individuals. Some may be earlier, some may be later. There are many other factors that come in play. Yeah. Okay. The family dynamics, the dynamics among the friends, and the individual itself. Okay, so back to primary prevention. It's, as I mentioned, is taking action before the occurrence of a disease, and we always aim at the whole population, ideally, because that is the most cost-effective way to prevent diseases. You can't just focus on one community or one group or one gender, certain age. Whole population is the best. Okay. But it will be relevant to certain groups or certain ages, depending on which condition. For example, health education, the use of condoms to prevent HIV. This will definitely be more relevant to for those who are about to engage in sexual activity or just engaging in sexual activity. So probably teenage and young adults. Okay, we want to give education on that because some may not be aware on the implications of unsafe sex, okay, including STDs, sexually transmitted diseases, HIV, and even pregnancy, okay, and even cancers, cervical cancer. So health education is very important. Food care is another one. It can be controversial because some may say it prevents ulcers. Some may consider it's a secondary prevention, to prevent worsening of diabetes and so on. Then the other one is an immunization for children, babies, right? School eye checkups, physical examination in children, pasteurization of milk. What does it prevent? Can can you guys tell me what does it prevent? Pasteurization. The days before they pasteurize milk, you can type in the chat box. Okay, some say Staph aureus, AGE. I think those days was brucellosis. Yeah, listeria. I think salmonella. Okay, infectious diseases, right? Okay. And then, uh, okay, what does it do? How does it? What does it prevent? Supposed to prevent dental cavities, caries, huh? Right? Yeah. But then some people are questioning it. I'm not sure you've heard of the U.S. Minister of Health. I think they call themselves Secretary of Health. It's some Nixon or something. He's questioning the need for fluoride. Huh? Okay, but currently, we're still using fluoride in water to prevent dental cavities, caries, and so on. Periodic physical examination of community, yes, very important. Okay, right. Okay. Secondary prevention. So from primary, we are moving on to secondary prevention. So earlier we wanted to prevent the disease in the first place, but secondary prevention is different. We want to identify and detect disease at the earliest stages. And you want to identify high risk communities and specifically focusing on chronic diseases, depending on the risk factors, okay, age, gender, race, okay, and BMI, family history, and other comorbids. Can you all give some examples of secondary prevention? Okay, somebody has mentioned pap smear, colorectal screening. Yes, very good. So pap smear is actually secondary screening prevention because it detects cancer at the earliest stage. It's not primary though. Mammography as well, yes. Uh, okay, obesity. Okay, that's interesting. Obesity, yeah. So you detect weight at the earliest stage. Prostate cancer screen. So all the cancer screenings, mammogram, pap smear, stool local blood, okay, prostate cancer is all secondary prevention because you want to detect disease at its earliest stage. Medical checkup, yes. Medical checkup because you can detect diabetes at its earliest stage. TB screening in HRG. What's HRG? TB
The
screening. High
HRG
risk.
is
Okay,
high
high
risk
risk group.
groups. Yeah.
High risk group. Okay. High risk group. Yeah. TB screening. So you want to detect TB at the earliest stage. Community program for hypertension, dyslipidemia. Yes, agree. So good. Okay. I think most of you understood the concept of secondary screening and secondary prevention. So the goal is to identify, treat, and monitor so that they do not become worse. Okay, we want to avoid advanced disease and symptoms. We want to detect diabetes at its earliest stage and start taking action, right? And screening tests are excellent examples, as some of you had mentioned. Cancers, even heart disease. Okay. Mm, and then, for example, ECG. Yeah, you may want to detect a heart problem.
Hi, doctor. I just want to ask, for screening tests that we do in antenatal patients for HIV and STD, so is that considered as secondary prevention also?
Um, yep. In a way, you want to detect the disease at its earlier stage, isn't it? Yeah. So yes, that is true. Yes. So you're not doing the test to prevent the disease. You're doing the test to detect the disease. Am I right? So you want to identify and treat and monitor. So as long as your goal is to identify, yes, then it's a secondary prevention. But if your goal is to prevent the disease, then it's a primary prevention. So can you all give an example of primary prevention in for HIV to prevent the disease in the first place? Anybody here? Yes, PrEP. Excellent. Okay. So PrEP is a very good example of primary prevention. You want to get them to avoid HIV in the first place. But if you have to start testing them with HIV, there's already a secondary prevention. Okay. Yeah. Thank you for the comment. Huh? It's a good one. So the activities for secondary prevention will be like screening, and then that will also include treating. After you screen, you want to treat. You wouldn't want to screen something where you got no treatment. Okay, so that's why pap smear is very useful because when you screen and you found it positive, abnormal, we are able to treat. We either send for colposcopy or if it's severe, then for surgical treatment. No? And then we are able to monitor that, right? We check on their blood levels or blood pressure levels or whatever. No? And then behavior plan, ideal weight. Okay, so like somebody mentioned obesity. So we can keep monitoring their weight, family culture as well. These are all other things probably related to For example, mental health. Okay. So what about Woolies? What kind of screening is that? Woolies test for mental health we do, isn't it? Yeah, it's a secondary screening. I mean prevention. Yeah. So you detect at the earlier stage if they're having some mental health issues. Yeah. And can be related to the family and individual aspects. Yeah. And role modeling. So another one is role modeling. So we doctors uh, try to be a role model for them by giving this advice, and hopefully we also follow the advice that we give for patients. Yeah. And so just to recap, primary prevention aims to prevent the disease or injury before it ever occurs, done by preventing exposure to hazards that cause these conditions. And there are also other examples of primary prevention beyond medical uh, fields. Can anyone give some example? It's not just in the clinics. There are also other primary prevention methods that we do outside the clinic, but relating to health conditions. Yeah, under occupation. Okay, IPT. Somebody mentioned that IPT in latent TB given for children. Okay, IPT. You want to prevent the disease, isn't it? Yeah. I think IPT I'll consider as primary prevention. Yes. Okay. Okay. Community activities. Okay. Such as what about road traffic accidents? Are there any primary prevention methods? The road traffic accidents, they can have severe injuries. Even, yeah. Seat belt. Okay. That's for cars. Okay. The law. Okay. Yeah. Okay. We need the law. Seat belt, helmet, car seats. Yes. Excellent. Okay. And of course, we need a law to ensure they do all these. So these are all primary prevention examples. And screening, I think many of you already given examples. Um, and treatment can be a primary prevention as well. So somebody mentioned PrEP, no? Okay, it's a primary prevention. So further examples will be, as you had mentioned, seatbelts, bike helmets, legislation and law to enforce ban or control of to mandate these use and also to prevent use of hazardous products such as asbestos, which we don't use anymore, and education about healthy and safe habits, okay, immunization. So I think given quite a number of examples, right? And so
Doctor,
again,
may I just give a comment about the IPT for the latent TB?
IPT, yeah.
Yeah,
Yes, Farah.
because I believe that would fall under secondary prevention because latent TB itself is considered it's already a form of the infection. So
Okay.
in those who we presume are having that infection which has not gone to full blown TB yet, giving the IPT would reduce those chances. So that's secondary prevention. I think primary would be like giving BCG to prevent the TB from becoming.
Yeah. You're right.
I
You're
think it would
absolutely
be
right,
like that,
Farah.
lah.
Latent TB is also part of TB. Yes, I apologize. That's an error. So yeah, BCG will be a good example, like vaccination. No? So to prevent the
Yeah.
TB in the first place, but more to extrapulmonary TB, isn't it? BCG. Yeah?
Yes, correct.
And
Yeah.
yeah, and IPT is to what do you call to treat latent TB. Yes. Yeah.
Yeah. Okay,
What
good.
about
Thanks. Just wanted to
IPT
comment
to prevent
that. For
TB in
HIV, is it?
HIV patients? Huh?
That's
HIV
also
patients.
secondary because we assume that they might already have that latent infection going on. It's an
Mhm.
assumption. Yeah.
Yeah. Okay. All right. Okay. All right. So IPT will be considered secondary.
Yeah.
Sometimes there will be some, difference because some treatment may be to prevent the disease, some treatment is to treat the disease. So we're treating, in this case, latent, we're treating, so it's secondary. Yes. Okay. So secondary is, I think, recap here. I was just discussing about it. Okay. So regular exams, screening tests to detect at these earlier stages is secondary prevention. Okay, low dose aspirin. This is another interesting one. Previously, it was considered as a primary prevention to prevent cardiac disease and conditions. But nowadays, I think many guidelines are withdrawing this recommendation. If at all, they only recommend for certain high risk groups or certain conditions with pre-existing cardiac conditions or high risk cardiovascular conditions. So probably it's going to fall more into secondary prevention, and then also in certain high risk groups. They're no more using it as low, what do you call, primary prevention. Okay, the other one is suitably modified work. So injured or ill workers can return safely to their jobs. So this like in Percaso and Soxo, they modify their jobs. So secondary prevention. And it can be what we call, it can be classified in different aspects, such as in the community where we do health promotion and other conditions like in accidents and seat belts, as I mentioned, right? Uh, uh, what do you call helmets, metabolic diseases, infections, as we mentioned, TB, HIV, mental health, okay, all the screening tests, those are immune compromised, okay, HIV, social conditions, employment, these are all the precursor ones. Then going prevention. Okay. So tertiary prevention is focusing on people who already have the condition and then they develop complications. So say patient with a heart disease already had a heart attack. Okay. So then we want to go on to rehabilitation or we take care of them, or patients who are having stroke, post stroke. So we are going to go for rehab as well. So we trying to fight the disease to prevent the end stage, improve the quality of life, and to prevent further physical quality of life, and then also include patients with cancer as well. You want to give palliative care, give a good quality of life, dignity to these patients, and so on. Any other examples in tertiary prevention you guys can think of? I mentioned like post-heart attack, stroke, and cancers. Any other examples? Domiciliary care. Yeah, so for multiple medical conditions, they may need domiciliary care. For example, changing a RAS tube and so on. Okay, CBD change, occupational therapy for arthritis patients. Yes, dialysis in end stage. Okay, that's interesting. Dialysis. Okay, geriatric support groups. Geriatric as in what? Oh, dementia centers. Dialysis. So the patient already has established CKD. Yeah, so we are doing treatment, but is that considered rehab? Okay, that's interesting. I got to look into that. Foot care in diabetic patient. Foot care in diabetic usually is secondary because you want to prevent ulcers. But if they already have ulcers and you're uh, doing what do you call wound care and all that, then there will be tertiary, suppose like tertiary prevention for amputation. So that can be can come. I think both secondary and tertiary. Chemotherapy and radiotherapy. If that's for cancer, so if that's for treatment of them. Okay, again, I think that's is that a prevention or treatment? Um, Pacemaker defibs, consider it tertiary. If it's helping them manage their condition, then yes, part of their rehab, yes. Preventing cardiac arrhythmias, I suppose, yes. Okay, these are interesting. Huh? Okay, I got to look into all this treatment. Prosthetics, yeah, for those orthopedic conditions, prosthetics, so it's part of rehab. Eye screening in diabetic patient. Eye screening, usually we want to detect the disease at its earliest, uh, what do you call, condition. So we want to prevent diabetic retinopathy. So we want to detect the diabetic retinopathy at its earliest stage. So I suppose it's detecting at earliest stage. So that's secondary prevention. If they're going for laser and eye treatment, then probably going to fall into tertiary prevention to prevent blindness. ACE inhibitors in CKD patient. Mm, CKD patient. So we want to prevent. Can you elaborate on that? ACE in CKD. But ACE is to prevent renal condition. They're already having CKD. I suppose is to prevent worsening. Okay, that's interesting. Okay, I got to think about it. Okay, I'll go on from that. So basically, the tertiary prevention is to treat and rehabilitate the persons, facilitate return to work, and follow up those who suffer or have suffered from work-related mental health problems as well. And this is the employee assistance programs. In Malaysia, it falls under Perkeso or SOXO, right? They have the prevention activities, and there are many services there. If at all it's confirmed to be due to work-related issues, so then the employer will give assistance to the employee through Perkeso or SOXO. So what are these services? Can be meetings for short-term assistance, could be financial aid as well. Some of them gets SOXO board assistance, monthly aid, and telephone consultations and so on by their officers. And frequently they make a reference to specialized resources such as physicians, psychologists, psychiatrists, social workers, counselors, even lawyers and rehab physicians as well. And sometimes they get the medical devices such as wheelchair assistance, walking aids, and so on. Some of them may get assistance to uh, for surgery, implants, medical devices, and so on. And what are the reasons this patient consult or get assistance from SOXO? Because of work-related problems. They may have burnouts, interpersonal conflicts, adjustment problems, and so on. I've had a patient who was uh, had an amputation like 20 years ago, and he's still having interpersonal conflicts with his spouse and a lot of mental health issues, stress, depression, communication problems with their children as well, and between parents and single parents if their spouse is passed on, legal issues, and some of them develop dependency problems. Start taking substances such as alcohol, even smoking, or gambling as well. Okay, I will go on to some questions, Q&As. A researcher had difficulty in differentiating between prevalence of a disease from incidence of a disease. How would you help him to define prevalence? What is prevalence? You would like to type in a chat box? Okay, I see that most of all of you all have actually typed out C. So, yep, the answer is C, right? So it's a proportion of diseased people at a given point in time. And how we explain this is incidence actually measures the rate of occurrence of new cases of a disease or condition, new cases. But prevalence is the total number of cases of a disease in a specific population. at a particular time point or over a specified period of time. So it's existing cases as compared to incidents is looking at new cases. So incidents will be more relevant for an individual. Okay, it looks at their risk of getting the disease, whereas prevalence will be of importance to policymakers as well because they're looking at total number of cases that are existing at that point of time. So to look at the burden of a disease, which will, have implications on policies, finance, and treatment, and so on. It's always confused with prevalence, incidence, and prevalence. As mentioned, it's the proportion of cases population at a given time rather than the rate of occurrence of a new disease. So incidence conveys information about the risk of contracting disease. So that's why I say it's important for the individual, whereas prevalence indicates how widespread the disease, important for policymakers. So these are the key differences between incidence and prevalence. So definition wise, it's the new cases in a population over time. That's incidence. Prevalence is all cases in a population at a time. So the focus on the disease risk and prevalence is on the disease burden. And incidence is always time bound. Okay? And prevalence can be point or period based, which I'll come on to in a short while. And incidence is used for identifying the causes and evaluating the risk. And prevalence usually is used for planning resources and assessing the impact. For example, in the NHMS 2023, so these are the highlights. They look at the prevalence of diabetes among adults. So overall is 15.6. Yeah. Now, which the known diabetes is 9.7, but those unknown is 5.9. So we do not have the incidence, okay, of diabetes, but we have the prevalence of diabetes. So the incidence will be of relevance to those individuals who do not know they have diabetes. Okay, what is their risk of getting diabetes? Okay, right. I'm going on to activity two. Would you like to answer in the chat box? You can type it in. Hello. Yeah, yeah, yeah. Just give me a minute. I've got an important call. Huh? Just hang- Okay, sorry, I was yeah. So all of you have answered B, and yes, that's the correct answer. So we're going to screen for high risk populations in the company, right? And so let's look at the other options. Promoting risk-free activities among the workers. Well, yeah, maybe can go on, but actually is also not logical. What activity is risk-free? Right? Even all of you are sitting here for next 1 to 2 hours is also risk of sedentary, isn't it? And we get higher rate, risk of chronic diseases, obesity. Yeah? And what about educating workers to a healthy lifestyle? Yes, that will be primary prevention. Treat the whole company with fluoride. Yeah, it's a primary prevention, but it's not a job of the company. It's a local water board, isn't it? Authorities to screen workers below 40 years old only. So this one, it's it's neither primary or secondary because we usually screen those who are high risk. So you should be screening workers above 40 years old. Okay, then yes. Okay, but if it's below 40, we don't usually do that. Lah. Yeah. Okay, next. Okay, I think I'll just on travel medicine. That's the next component. Also very important aspect of public health and also in primary care. This is some old data in 2012. Okay, and maybe I have to update it. And whom it falls on, usually it's falls on to the foreign office, pre-travel advice, and doctors. Usually it's the primary care doctors who deal with this travel medicine. No? We don't have a separate travel medicine clinic. Yeah? So normally they come to the usual family doctor and they ask them, or they may ask some advice before they go for their travel or after they are back from the travel. And so we need to give some effective advice to these travelers, both pre and post travel. And we need to communicate the risk clearly to them. And we also need some travel advisories from the government. Sometimes we base on the travel advisories for some specific information. So, for example, certain vaccines or certain places to avoid and so on. No? And this discipline has been already been developing quite dramatically. There are also international societies for travel medicine, and there are also journals as well. But in Malaysia, I think it's still uh, maybe in its infancy, I suppose. Yeah, but it's definitely related to other disciplines such as infectious diseases and public health. So it deals with also drugs, vaccines. Not all are infections. There are also non-infectious travel risk, major syndromes in return travelers, as in your assignment two. The question was on major syndrome of a patient who came back after travel with fever, access to travel medicine resources, and time spent in uh, travel medicine. That one, I think we don't have a specific one here, but we can always attend CME. Some of the courses have CME. So, and these are the elements of travel medicine. There's just too many. So I'll just focus on few aspects such as immunization, very important, and what are the activities you can do so we can advise them accordingly. So besides immunization and the vaccines, the other one is travelers diarrheal prevention and self-treatment. Travelers diarrhea is one major part. So we should be able to counsel them accordingly and to advise when to use treatment and also when to give antibiotics. In the previous group, I had given this assignment on treatment for travelers diarrhea for this as intake. I've gone back to the assignment one on obesity and assignment two on malaria. So but I think I might change back to this travelers diarrhea for the next group. Okay, malaria prevention is one important uh, aspect of travel medicine and also treatment of malaria if they come back. Okay, right. Motion sickness, uh, altitude, okay, those climbing mountains. Okay, advice you need to give. Animal bites and rabies avoidance. Now we have nice, good guidelines in Malaysia on how to treat for rabies and animal bites, including our national antibiotic guidelines. Okay, business travelers. Okay, there's also on this what do you call DVTs among those travelers in airlines. Pregnant women, when can they travel? When they should not travel, especially for airlines and so on. Okay, and these are the components. I think it's included in your module. These materials. I've given quite a bit on traveler's diarrhea. Okay, most of it is from Murta. Yeah. And also malaria. Malaria I've taken locally from our national antibiotic guidelines. Having said so, do make sure that the guidelines are current because our current guidelines are no more in hard copy. It's a live document because the uh, drugs that are advised to be taken keeps changing. It depends on their resistance pattern. Yeah. Okay, this okay, DVT prevention, altitude illness, as I mentioned, as all this may come out in your single best answer ones. But having said that, okay, the major cause of mortality is still cardiovascular disease during travel. Once I was in a tour and the tour guide had to stop halfway to send back one of the senior citizens who died due to a heart attack. In fact, most of the tours, a lot of them are senior citizens because once they're pensioned, they have more time. Right? Unlike most of us now, most of us sitting for exams, I don't think you'll have time for much travel, isn't it? Yeah, tours and whatnot. So then again, their risk for heart disease is much higher in the elderly. Accidents and injuries are the next ones. Quarter of it. Infectious disease, though is covered in this module, the actual percentage is actually very low, 3%. Travelers' diarrhea, though they do not usually die, okay, but it gives a major morbidity, about 50% among all travelers. Yeah, I've had travelers' diarrhea previously. It's very troublesome. Definitely can ruin your holiday, right? And you, in many days are wasted, being sick and all that. And so we should be able to evaluate the risk for preventable travelers travel related illness or injury and to advise appropriately, which will include vaccines or even chemoprophylaxis, usually it's antibiotics and so on. And the other one is, for example, vector related conditions such as insects causing malaria or other infections. You should know what repellents or mosquito nets and medications and vaccinations. Ingestion of safe water. I think I've given in some of the material what kind of method to purify water or to make it safe, you know, to be taken for intake. Other protective wear. Cystisomiasis not so relevant here. Which country is it relevant? Yeah, not to. Yeah, more to Africa and some parts of Egypt. Yes, some parts of Egypt. Yes, but I wonder who wants to go into the water. Most of them in Egypt they want to see the pyramids. It's like, yeah. Yeah, but of course they travel in the canal. Have a nice Nile River there. And of course, we advise for insurance cover. In some countries, actually, it's mandatory to take insurance. This is the geographical reach for malaria in most all of Africa and Asia. So this is a very easy question. You'd like to type in your answers. Okay, it's very easy. Yeah, it's a bonus question. Answer is A. Okay, that's malaria. And what investigation? Somebody typed in S. It's an error. Okay, thick blood film for malaria as well. Very simple, isn't it? So it's in your assignment as well. So the other one, this one I'll go through very quickly. because it's just to make you aware of the components of occupational health. So there are some measurement and certification. There are generic measurements such as health measurement codes, and there are different codes for different concepts, right? And the one generally that's used for international codes for measuring health is ICFDH, right, to standardize descriptions of health and disability. And this one consists of four domains: body structures, body functions, activities participation, and environment. Okay. Going on further, this one is very important: disability, because as in SOXO and PROCASO, employee assistance programs, they use this term for disability, and it's further defined as three different types. One is impairment, one is limitation, one is restriction. Which is the most severe? Is it impairment, limitation, or restriction? Obviously, it's going to be impairment, isn't it? Yes, impairment, yeah. Because they lost a body function, for example, amputation, right? They lost a limb or so the dysfunction. And this the one that usually calls for compensation by Soxol. The other ones are a bit more tricky. They may have some dysfunction, limitation, where the difficulty individual may experience executing a particular activity. So let's say they have some deformities, say rheumatoid arthritis, or in diabetic foot, they have some ulcers or restrictions they may have in certain life situations. For example, in mental health conditions, they have anxiety conditions. They may not be able to see customers or patients. For example, I've had a pharmacist with anxiety problem. So restricted is working as such. He is not able to see patients. So he was shifted to the storeroom. Right, then he was able to function very well. Okay. But I think for doctors, it's a bit difficult. Because most of the time we see patients, isn't it? Very few disciplines in medicine without seeing patients. Which one doesn't see patients? Which discipline? Peto. Yeah. Okay. So for those who radiology, okay, radiologists, yeah, blood bank they see patients, okay, but they deal with blood, lah, no? Radiologists, yeah, most of the time, but then they do ultrasound, isn't it? Yeah. Yeah. So some public, okay, public health, okay, yeah. Yeah, but I suppose they have to see the public though. But we don't see patients. Forensic, yeah. So forensic as well, but they see dead patients, not live patients. So okay, so but I think medicine one field most of the time you see patients, only certain subsets, you don't see patients. Okay, then leading on to that, then we give the sickness certification. So this part I think not really very important for us, just for awareness. Okay, it's more the occupational health. And it's a subjective decision because it also involves the economy. A lot of people go on leave, then economy will be down. And so it's a subjective and complex issue. And for us as GPs, it's a bit complicated, but maybe fortunately we are not really dealing with this SOXO. They have a SOXO board to deal with this decision. So this is another question. Would you all like to answer? Yeah, I think the answer most of the time, most of the groups will say either B and C, yeah. But the correct answer is C. Okay, we still fall upon the act eventually. Okay, the but the body that's providing the act is the National Institute of OSHA and NIOSH. That's why you take the exams, isn't it? But the actual sets standards is from the Act itself. I think this question is tricky, not fair. Might remove it in future. Okay, this one is a repetition of the earlier one. Okay, I see all answered A. I'm not sure whether everyone is just. Ah, yes, somebody answered B. Yes. Okay. All right. So you don't follow the crowd. All right. Okay. So the answer is B. Okay. We do not usually do periodic medical examination on all employees, only high risk ones. Okay. We only do the initial medical examination on all employees. For example, if all of you are doctors here and you became a houseman, you need to do a medical examination, right? So that's your only time you did a medical examination. But for those of you here, I'm not sure how many of you are above 40. So that's when you're considered high risk. Then we have an annual examination. For those in KKM, we have an annual examination, mandatory, yeah, for all those above 40. Okay. When you're 40, that's when you realize you need to wear glasses. And that's when everything starts. You need to do an annual examination. But periodic medical examination on all employees is not cost effective and it is not necessary. And neither should you do extensive clinical exam and investigation on all employees, not cost effective. Periodic medical examination, not work related illness, not their work, and information transfer to the employer automatically. No, not really. Yeah. Okay, workplace certification. Okay, this one is looking at the importance of the occupational, what do you call, act. Okay, there are certification, there's standard operating procedures, so that the workplace is safe for each individual and they what do you call, comply with the existing what do you call, laws, yeah, NIOSH, National Institute of Law. Right? So this is another question. Okay, so all of you are correct. So it's aggravating a pre-existing condition at the work workplace, right? Okay, this one is more like a trivia question. So answer is B. Yeah? Okay, what about A? What do you call that? A non-medical person who by chance is at the scene of an emergency. Yeah, that's a good Samaritan. Just any random person happens to be there and they help. Okay, yeah. At the scene and they're also helping. But they're at the scene and they're not helping, then it's not relevant. Right? At the scene and they're assisting. Right? Okay, the rest are all different. Okay, I think coming to the last part, environmental medicine is the multidisciplinary field involving medicine, environmental science, chemistry, and others. So, for example, in this picture, so you see at the bottom, there's the earth there. So there are chemicals there. And on top are the flowers and the plants and the trees. So that's a biological component. Then that's the house, and that's a physical component. Okay. And then inside the house, there are humans living there. So that's a social component. So it's physical, chemical, biological, social, or any combination. Okay, well, that is what we call as environmental medicine. It's a broad field, can even include ozone depletion, UV radiation, and then how it causes skin cancer and all. Nowadays, some of them call it as planetary medicine even. There's one in Sunway, headed by Prof. The one in Mercy last time was Jamia, Prof. Jamia. She's heading planetary medicine. So they look at nuclear accidents, radioactivity, mercury poisoning, heavy lead poisoning, and so on. And it also has loss, Delhi's loss due to environmental causes. So, next question. So, some of you answered A and some answered D. The answer is A, the relationship between exposure and the disease. Right? Okay, this one is a bonus question, very easy. Okay, I think all of you all got it correct. So, it's a pathognomic of anthrax pneumonia. It was kind of popular many years ago during the 9/11 attack. A lot of terrorists going around sending anthrax, but daily no news of this. Okay, I think we're done. Oh, okay. All right. Okay, actually, I had a few more slides on the assignments, but I think that's fine. You guys already submitted your assignment, isn't it? Yeah. On the obesity and malaria. So I think should be okay now. All right. So any questions so far before I pass on to Farah? Yeah, I think just nice, isn't it? Another 5, 10 minutes. Hi, Farah. Any questions, guys, before I pass over to Farah? Anything in chat box? Okay, no, no questions. Okay. Are they all
Yeah,
understood
I
everything
don't see any
or
other questions.
no, no,
Your
okay.
talk was too cemerlang lah, boss. That's why no questions after that.
Oh yeah, you're being too kind to me. Okay, Farah. So I'll hand over. Honor is yours. The platform is yours now.
Okay, thank you, Dr. Paran. So I'm going to give you guys a little briefing about the next activity, which is scheduled to start after the break. If we look at the program, we're supposed to have a short break, 3:15 to 3:30. For the Module 5 activity, you'll be divided into 8 groups, and there'll be 8 breakout rooms. So each group will have their own activity topic to discuss and present. So in a while, I'll upload all these activity files in the chat box and your groupings. So group 1 will do activity 1, group 2 will do activity 2, so on and so forth. So each activity topic will have a number of issues, but you'll only need to choose one issue to present later. So when you come back after the break at around 3:30, in the breakout room, you will discuss with your group members the issues for that particular topic, and then you choose one issue to report on. Your group can compile the points in Word or PowerPoint format, and then you assign one spokesperson to present that chosen issue later. So in between, me and Dr. Paru will pop in and out of the breakout rooms from time to time to see how you guys are doing. But we expect everyone to contribute something to that group discussion. So around 4 p.m., the rooms will be each group spokesperson will present their issue and discussion, starting with group 1. You can share screen to project your points, and later afterwards, share your presentation document in the chat box for everyone to learn from. We estimate each group presentation would take about 6 to 7 minutes long, maximum 8 minutes, so we can finish all 8 groups by 5 p.m. So my advice is, because you only have about 20, 30 minutes to discuss in your own group, don't spend too much time trying to choose the issue. Just choose one quickly and then work on the points together with your group mates. And then we'll see how it goes from there. Okay, so Dr. Paran, anything else to add?
I think it's okay, but are they all right with the grouping? Are they quite a number of candidates were not familiar which group are they in? Hope you all
Yeah.
have received your
I'll put the
grouping.
groupings in the
Okay, okay,
chat
okay.
box as well in a bit.
Yeah, okay. All right. I think that's fine. All right, that's it. Yeah.
Okay. All right. Just a moment. Okay, so just give me a second while I try to upload the file. Okay, I hope everyone can open the yeah, I think it's already uploaded. So if you can try to open that PDF file, you can find your name and know which group you belong in. And then later on, our host will create the breakout rooms, 8 breakout rooms for the group discussion. Okay. So is everyone able to see the activity files that I've uploaded in the chat box? If you don't see it, you can PM me and I'll try to upload it again.
Hi, Dr. Farah, are you there?
Yeah, yeah. Hi, I'm here.
Sorry, Doctor, we are
Yes, Kumuta.
confused. Sorry,
Oh,
Doctor,
okay.
I'm Kumita here. We wanted to ask how do we go into meeting rooms?
Ah,
Do we wait or?
no, because the breakout room session is actually supposed to be after the break. So after this, the APM
Oh,
host
okay.
will create the rooms for you. Yeah, yeah. So
So,
I just wanted to check if everyone has their names. If you don't have your names in the PDF file I sent, just PM me and I'll just assign you to a random group.
all right. Thank you, Doctor. Sorry.
Okay, thanks. Okay. Hi, everyone. For those remaining in this main room, which has now become breakout room 7, can you guys hear me? Is everyone back after the break? No response?
Yes, doctor, can hear.
Yes, Doctor.
Okay. Hi, Dr. Shalini. Okay, great. Okay, so you guys have the assignment. Sorry, that word file that I shared in the chat box just now.
Yes, Doctor.
So if you guys are in group 7, then you'll have to download activity 7. Okay, so what's going to happen is that you guys will have about 20-30 minutes to discuss. Okay, and by about 4 o'clock, everyone will come back into this main group, and then we will present one by one each group. So what I suggest is, amongst you guys here, choose someone to be like a note taker, create a Word file or PowerPoint document, and then everyone start discussing and talking the points about that activity. Is that okay?
Can I just add one point, Farah? They
Yeah, sure, Dr.
only
Pan. Yeah.
supposed to choose one out of the multiple
Yes,
assignments
that's right.
within their group, not all of it.
Correct, correct.
Yeah.
So, have you seen the activity file yet? Activity 7 on quality and safety. So, if you see among the outcomes there, so general outcomes, there's actually 8 listed, but you just need to choose one and then discuss it and come up with the answers or ideas for it and discuss. Okay, so one person should take down these notes, compile it into either a PowerPoint or a Word file, and then later on, that spokesperson will project it and then talk about what you guys have discussed. All right, can we do that?
Doctor, just want to clarify. Let's say like
Sure, yeah.
yeah, like my group number 4, we have like
Hey,
general
group 4.
outcome.
Sorry, this is for group 7 sebenarnya. You are assigned to group 4, is it?
Yes. So I go
Okay,
to
you're
the
supposed to join breakout room 4 actually.
okay, and then
Yeah,
once
because
I
this main group
join,
has now become room 7 due to some technical mistake
okay.
lah.
Thanks.
Yeah.
So
Yeah, so
we just
yeah, you
come
can
up with
join your group first lah.
okay.
Okay. Okay, thanks. Okay. Okay, so for the rest, you can start your discussion now because me and Dr. Paran, we're going to go to the other rooms and sort of like get the ball rolling as well. Yeah? Okay? All right.
So, Farah, I will go to group 8, 6, and 5 first.
Okay, sure. I'll do
Yeah.
the 1, 2, 3 first. Okay.
Yeah. Okay.
Okay. Bye-bye.
Hello.
Hi guys.
Hi guys.
Shalini here.
Yeah, Amira. I think easier to discuss kalau kita unmute kan?
Ya boleh, tapi kalau semua bercakap satu kali, that's gonna be problem.
Yeah, agree.
No, just wondering just now, Dr. Farah kata kita question number 7
Yeah, correct.
Okay. So, hi guys.
Hi, hi. Hi, name Selvam here. Sorry, I'll be in this one. I'm still trying to follow up with you all because I'm driving, bringing back my son from Batunia. So if I'm not answering, I'm just bear with me, Sola. Sorry, on this part.
Okay.
Okay, so who are going to take down the notes and who are presenting? And anyway, macam mana nak buat presentation dekat sini?
I can jot down the notes. Maybe we'll do in words. Tapi how do I share screen here? Because this is not, ni bukan kita punya ni kan?
Ya, kejap I try tengok.
I rasa macam boleh. Yang dia
Tak,
share button dekat bawah tu boleh?
Boleh. I ingat tak boleh. Okay, kejap. I do words lah.
Anyone boleh share kot kan, not just the host, right?
Kejap.
And then which topic kita nak
Yang dia
present?
post in the group tu, they do AMS audit kan yesterday.
Oh, kejap. Ada.
Ada, they post in the group. Because our question, okay lah, I share screen lah.
Lama, I'm using phone and laptop macam kelang kabut kejap
Can see my screen
Belum keluar lagi, tapi dah
Belum keluar lagi.
Started sharing. Started screen sharing.
Okay.
Okay, can see.
Can.
Okay, this is our task lah, activity 7 regarding quality and safety. So this is the outcome lah. Choose one. Oh, yesterday's one. Kejap I show.
Yesterday one they did AMS audit.
Ada AMS audit. Alamak, but I kena download lah. Sekejap.
Antibiotic resistance tu.
I send back in the WhatsApp group, boleh tak you all tengok? Sekejap
Means like kalau kita buat macam mana? I mean like kita buat satu outcome je kan?
Ya, satu saja.
I tersilap ni kuning. I send back.
We need to decide what kind of audit we want to carry out. Is it either antibiotic ke? Apa lagi audit yang ada kat KK? PPC audit, infection control.
Yang yesterday they do AMS. We do banyak audit kan, kalau kat KK ada ISO, apa tu, infection control.
Tapi maksudnya yesterday tu diorang ambil general outcome yang mana? Because general outcome tu kita kena pilih one of it kan? Macam a list of the reason for carrying out audit. So kita nak stick to which outcome?
Number one macam dia senang.
Kan? The list of reasons for carrying out audit kan?
Audit in your clinic.
Tapi kalau macam number one tu kita tak payah pick exactly like macam antibiotic ke PPC ke, kan dia macam generally reason for carrying out audit. Is it like that?
Oh, I think the yesterday's group choose a different outcome. Dia choose yang number 4. Number 4.
Yeah.
Because if you guys choosing number 1, then we have to come up with our own answers lah. No need to be specific to any audit rasanya. Just list down the reasons.
So we take number one.
I think number 1 nampak okay kan?
Semua setuju ke?
Just this one. Kalau kita nak tengok daripada klinik kesihatan, kan kita ada pencapaian dia kan. There is quite a lot, you know. Like colorectal, TB, pain score, and then fundoscopy dengan diabetic, PPC and pap smear, mental clinic, HIV and PrEP, asthma. But this one is my clinic lah, because I'm from Miri kan. So this is what my clinic will do lah.
These the reasons for carrying out.
Yang bawah tu dia kata your group must discuss the above issues and choose one issue to report. So isu apa macam mana?
Maksudnya tadi Dr. Farah dah sebut lah, dia kata pick one of the outcome.
One of the outcome.
So I think boleh pilih yang nombor 1 je lah kan, and start talking about that.
Boleh? Setuju?
Or shall we ask her juga?
I think it's the first one kan. I mean because KK setting tu dia ada banyak. So we can explain to this one lah.
So we choose the first one.
Ya, boleh.
I think we try with the first one and see lah.
Agree.
Whatever works lah.
Okay.
Itu saya nak tadi. Macam mana tadi? We have to answer general macam ensuring patient safety, improving patient care, or be specific of certain services.
Nitish boy, hold Appa's phone for a while. Just try to listen.
I think mainly for quality or those kind of things, right?
Yeah, so kalau macam tu, we can say first one maybe ensuring patient safety and improving patient care.
Dia macam general je lah kan.
General je lah.
Oh, okay. First, okay.
The others okay tak? The others okay tak? Kalau ensuring patient safety and improving patient care.
Yeah, okay.
Betul.
Patient safety and
Improving
patient
care or management.
right.
Another example kita boleh ensure evidence-based practice are being followed, like macam kan ada audit pasal antibiotics kan so to make sure that kita memang pakai evidence-based.
Boleh?
Ensure evidence-based practice are being followed.
Okay. Can we put something like meeting regulatory requirements? Kan kita ada KPI semua tu kan? So make sure we fulfill those criteria lah.
Guys, what about those infection control? Because for like when we do a clinic in GP setting, when they come for inspection, there's a few things that we need to follow from CCAP's punya regulation, So few of the things are like infection control, and then after that sharp bin users, those kind of things. So all that all that are audits for GP clinic lah. And then they'll come and check your temperature for the vaccines to make sure that you have a temperature monitor, those kind of things.
Sama obeying the standards lah kan, betul tak?
Yes, correct.
Okay.
Proper collection of data.
Yes.
System.
Correct.
Sorry again?
Proper collection of data with system.
And also with PDPA lah.
But what's the reason for that? I mean, proper collection tu reason dia apa?
Medical record purposes.
Okay.
Medical record purposes, audit purposes.
Yeah.
All this yang akan show that the quality has been up to standard macam yang ISO punya.
Maintain accurate medical record.
Betul sebab macam okay.
Medical record.
Maybe accurate and something kot macam betul dan
tepat.
Continuation.
Take up dulu.
And solid proof macam apa?
What about resource management?
Oh yeah. So that daripada data we know lah macam nak apply for apa kan.
Yep.
Sorry nak tanya,
Pastikan yang
is the challenges of quality and safety in family medicine kan? Challenges. So this one has to be what are the challenges we are facing to achieve the KPI or target, right?
Yeah.
Betul tak? So first of all, the data collection will be limited lah or not properly collected. Boleh kan? Because I'm reading, I stopped the car for a while. The part 1 is challenges of quality and safety in family medicines. So since the part 1, so there will be like the poor data collection or lack in training to monitor quality improvement.
Oh, so I think we can
presentation, sometimes we were expecting something else tapi macam monkeypox, but then getting the monkeypox, we misinterpret the thing. Because I know sepintas lalu je saya baca challenges of quality and safety, tak silap saya. Challenges kan.
Correct.
Even though we all can achieve the ISO, but the data collection will be limited ke problem to achieve the target type of patients problem, time constraint and workload, poor orang yang bekerja, I mean less staff.
Or should we do in a table form?
I
Challenges?
think that would be better.
What? Kan? Challenges and
Yes.
what? Sekarang. Sekejap.
Because I worried later they may ask what can you do for improvement. At least we have the comparison kat sana lah.
Tapi Dr. Farah kata just kita discuss around the one of the outcome saja.
One of the outcome,
Yeah,
because this one
and
is dia
some more,
cakap challenges kan. That means what are we
yeah.
facing in
Tapi I rasa
in
dia takkan
problem
tanya
of
macam takkan tanya lah macam that detail. Dia pun 7 minutes, 8 minutes je.
Nitish, hold up phone. Near to me. Yeah. Okay.
Our discussion is berapa minit?
I think macam tadi macam 8 minit kot Dr. sebut.
Oh, okay.
Around 8 minutes. Paling banyak 8 minutes lah because I think they want to put everyone 5 minutes to 6 minutes.
Yeah.
Kita just discuss point number 1 je lah.
Yeah.
Yes.
Alright.
So yang kalau challenges what I can think of is like time and constraint, over workload, not enough staff. The clinical CPG tu betul tapi the inconsistency kan dia akan tukar. Which I think lah. And then information on what data we are collecting may be incomplete.
Do some
It's
simple
not the one that I can think in my clinics lah. That's why I just inform.
Incomplete data, and then
I think the ensuring patient safety comes under challenges also.
Patient
No,
safety, I
that's
think it comes under because it'll come under the disease presentation.
Okay.
Like the one we all had that day, a colleague of mine actually diagnosed as monkeypox, but it was not monkeypox. Things like that. So we actually became give the patient anxiety at a particular moment lah. So it can be on that.
But what about if let's just say we put the monkeypox punya issue, right? Okay. So let's just say a patient came in just like cough, running nose like that with some symptoms which we are not sure, and then turns out he is monkeypox, but he's been sitting in the crowd for at least about an hour or two waiting for his name to be called, and at that time that would have triggered.
The spreading of the day, like the
Correct.
incomplete because of the incomplete patient presentation. I mean, because no one able to catch it, and even the patient was unaware. Like for us in Sarawak, it's a bit very tedious because some patient they come without knowing what the disease is from pedalaman. So when they come in, they are sitting in the crowd, and by the time we call in, and then everyone gets hyperventilated.
Correct. But isn't that one of the challenge?
Yes, it is one of the challenges we are facing.
So
sometimes the patient will say, I have only fever and cough, but patient is actually having chickenpox and sitting around the whole crowd.
Correct, yeah, true.
So we should say like proper macam isolation area, proper facilities like that ke?
And the triaging part, because of due to lack of staff and all workload lah. Over too much workload, very little staff, time constraint, so everyone is rushing for everything. Ini kekurangan Sarawak. Sorry.
But is it related to the audit?
Yes, because all this will come in certain audit also. What infection control habis koyak
infection
benda tu.
control lah. Okay, under infection control.
So koyak benda tu.
Tak cukup
And
orang
then limited
is
resource.
not,
Please put this. Sarawak memang limited resource.
Tapi okay lah.
But please double confirm because tak silap saya, I read the thing is challenges of quality and safety code.
Yeah, tapi related to audit lah.
So it will come under audit also.
Quality. Resource management, and then how to write the ayat for apa proper quality and safety for the patient and the staff.
How would due to high volume, patient terlampau banyak, so limited time to assess because very less staff.
Yeah. So that one, so when audit is to
Ensure adherence to
Documentation,
the
of course, will lari lah for this one.
to ensure adherence to the apa protocols or standards.
compliance. And
Okay. Resource management.
okay. Resource management.
Accurate.
Under challenges tu can add on lack of training for staff.
Betul? Lack of training of staff. Train tak boleh lah.
So daripada audit tu we can identify lah kan.
Because sometimes audit kan part of the audit the
annual CME, annual CME
yes,
tu kan.
It's part of the checklist of the audit lah. Sama ada klinik tu ada buat CME ke tak kan.
Betul. Macam like I think last year Perak dia mewajibkan semua MO pergi course dengue.
Betul. Identify under training and to ensure CME is conducted in the clinic.
So and train lah kan. Nanti kita buat contoh dia CME lah. Proper practices lah. CME course.
Conduct CME ke short courses.
What else? Kalau patient ni macam NCD patient kena aim for HbA1c less 6.5 tu kita kira management tu lah ya?
Macam mana? Kalau
kan kita ada NCD punya audit kan macam ensure HbA1c less 6.5. Yang tu kita nak cakap pasal mismanagement of patients ke?
That one NDR kan, audit NDR. Dia ada proper guideline kita kena follow, whether this patient ada refer dietitian ke tak.
Betul.
Refer to DM tech pharmacist ke tak kan.
Itu nak cakap
list lah basically.
Itu macam nak cakap bahawa patient safety and improving patient and care.
Improving patient
kan?
Betul.
Ni dah cakap dah ni. Dekat mismanagement.
Yang kat atas tu kan? Itulah rasa macam kat atas.
Dah cover kan?
Dah cover. Yang tu yang sama je lah sebenarnya kan dengan ensure evidence based practice tu kan?
Betul. Ikut CPG lah.
I tambah sini lah macam multidisciplinary care referral semula kan.
Dekat GP ada financial punya audit tak? Macam
financial punya mainly financial punya tak adalah because that one is usually under because if let's just say we are under Sendian Berhad then we have those financial audits lah. Company punya audit lah.
Internal audit
yes.
Sebab mesti ada kan?
Betul.
Kalau nak tanya yang BLS tu ada tak? Basic life support. That means yang tu datang I assume under staff
train kot. Under train staff kot.
Okay.
Guys, what about vaccination for the staff itself?
Memang kita ada vaccination.
Influenza tu ada. I rasa ada audit. COVID dulu pun ada rasanya.
Kan? Does that fall under anything?
That one is under
apa tu yang staffnya healthcare tu.
Kepas.
Dia akan ada satu
Kepas kan,
MO
kepas.
yang in charge that
Ah.
portfolio.
Yes,
yang
betul.
40 years
Kepas
old
tu.
kena 40 years old kena screen tu apa semua.
Tu kepas kan semua.
Kepas.
Kepas lah. Tapi yang tu dalam because kepas ada audit benda tu. It's in
Healthcare provider safety.
healthcare personnel. Dia bukan patient kan.
Betul. Healthcare screening apa?
What other audits you all get,
Infectious control, ISO.
What about those those dengue and all that we have to notify and all that consider under audit juga kan? They'll come and check whether you are.
Yeah, audit.
That one CDC ke audit
Yes, correct.
Kalau MCH pun ada. MCH banyak juga audit sebenarnya.
EMTCT.
Antenatal pun ada banyak.
Antenatal, whether
What about the fundoscopy, visual acuity semua yang under this one? Under workload lah kan?
Ada.
Yang tu juga pasal patient care juga tu yang tu yang
Okay.
Fundoscopy mainly for diabetics.
Improving patient care. Kita nak tambah lagi satu ke?
Actually this banyak pasal patient care je kita buat audit ni instead of
betul.
Ya betul.
Maksudnya bukan yang ni kalau challenges ni macam maksudnya tambah improving lah juga ya.
Betul. Actually kan I rasa kan dia letak improving dulu sebab kita bukan mismanage dulu kan macam
okay. Avoiding
Actually ni pun dah cukup dah nak 7-8 minit tu.
Nanti kita suruh Abang Selvam kasih goreng sikit.
Yes.
Terus Abang Selvam ya.
Okay, I share lah. Cukup betul lah. Ada 3 minit lagi.
Rasanya macam boleh goreng dah ni. Incomplete data, accurate information.
Ada accreditation ke kalau untuk KK semua? Sebab usually from hospital diorang akan ada apa JCQ lah apalah.
ISO tu kan?
ISO.
Sirim audit.
Sirim
audit.
Sirim audit for all the equipments lah kan? Those things.
Sirim ni equipment, environment, staffing, semua sebenarnya.
Lepas tu breastfeeding ada juga.
Semua. Tapi actually macam dah semua kita punya points ni actually dalam sirim pun ada. Dan e-courses pun semua check. Even the APC and yearly pun ada check juga. Macam dah termasuk lah.
Nanti nak present tu Ruzana akan tunjuk this one ke?
Boleh.
Then the person cakap je lah kan?
Kita share screen dia ya. Okay.
Most likely kita yang present dulu kot.
Sebab because we are the main group.
Memang in the main group.
Kita tunggu Dr. Farah atau Dr. Farhan join our room kan?
Oh iyalah. Sebab tadi Dr. Farah cakap 1, 2, 3. Dr. Farah pula.
They will go from room to room kan?
Just now Dr. Farah dah masuk dah sekejap and then dia dah keluar.
Oh iya ke?
Ada dia tengok je.
Ada rasa. Betul lah tu. Ciwa. Kan nanti untuk atas ni.
Okay. Hi everyone. Those in group 7, you already have to start wrapping up your discussion because everyone is going to come back into this main room, and then we're going to start off the presentations. Okay. Siapa spokesperson for group 7? Anyone from group 7 can answer?
Dr. Salvam will present, betul?
Yeah, but we're going to start with group 1 first. So we wait till everyone has come back into the main group lah.
Okay,
Okay.
sure. Right.
So just start wrapping up and saving whatever files you need to save lah. Okay.
I think it's done, Doctor.
Okay, great. So we'll just wait for everyone to go back into this main room. All right.
Alright, sure.
I think the screen share maybe no need lah kot sebab the rest akan masuk kan.
Unshare first.
Unshare first lah.
Okay. Thank you so much. I continue driving.
Okay. Hi everyone. Welcome back into the main group. So I believe everyone would have already wrapped up all their discussion and compiled the points together. Yeah. So what we're going to do now is to let each group present one by one, starting with the first group. So I'd like to invite the representative from the first group to, you can either share screen and or project your slides or something, yeah? Either slides or Microsoft Word document or whatever document, Google Docs on the screen. Uh, anyone from group one?
Yeah, hi, Dr. Farah. I'll
Hi,
share.
Dr. Hi.
I'm Edwina. Yeah, I'll share my screen from group one. Sorry. So we did the assignment was activity one was professionalism, ethics, and law, and PL. So how does a doctor approach medical ethics in their practice? So we divided it. We chose the outcome situation number 3, which was how does a doctor approach medical ethics to practice the ethical responsibilities as practitioners to their staff, to society, and at home. Anyone from group one to present? Hold on. We separated it into the four ethics, which was beneficence, non-maleficence, autonomy, and justice. Doctor's approach to staff, if in beneficence, would be to support the professional development and the well-being of staff. Our example was to ensure a non-toxic work environment. And in non-maleficent sense is to not discriminate or undermine our colleagues, to not tolerate verbal abuse, physical abuse, or any kinds of abuse. And the autonomy, we would have to respect our staff's rights and allow for space for them to voice concerns. And for justice, it would be to treat all staff equally. In the society sense, as a doctor, we should be promoting health education and disease prevention initiatives, like engaging in health screenings and physical talks, also to protect patient confidentiality in our practice. Non-maleficence would be obligation of a physician to not harm the patient. Autonomy, we need to respect cultural, religious, and social beliefs while also promoting public health, and to allow communities to make informed choices, especially regarding vaccinations and screenings. Justice-wise, to society, we should be reporting diseases to the respective authorities to prevent outbreaks. For example, if there is infectious disease outbreaks. There's also an additional point that we didn't know where to put it into, but which is to our responsibility to combat misinformation by the public. For example, getting false information from online sources. To the homes, we would need to contribute positively to our families' well-being. In non-maleficent, we should prevent any emotional or physical harm to them. And in a sense of autonomy, we should allow each member of the family to voice their own choices and opinions regarding their own well-being. And under justice, as doctors, we need to treat all family members fairly and equitably. So that's from group one.
Yeah, I have to say your group did exceedingly well because most of the time over the years I noticed that people always choose the other outcome, which is about the break news, something which is some kind of clinical related. But I think your group is the first group I've seen that actually picked this topic, this issue about ethical response to the staff, society, and to the home. So well done, very good. And I like how you guys divided it into the four main ethical principles. It's very organized. So well done. So applause to
Thank
group
you.
one. Yeah.
Thank
So
you.
if you don't mind, you just share this PDF file in the chat box so that
Yeah, sure.
everyone can learn from it as well. Okay.
Okay. Yeah, sure. Thanks, Dr.
Okay.
Farah.
Well done,
Thank
group
you.
one. Okay. Great. Okay. So that's a very good start. How about group two? Do you have a representative to present? Anyone from group two? Yeah. Okay, great. I can see your PDF already in the chat box. Okay. All right. Anyone from group 2? Maybe I'll just start calling the names out. Okay, I think in group 2 there is supposed to be Fatin Napisa, Dr. Gita Naidu, Dr. Hanif, Dr. Hidayah, Dr. Hang, Dr. Imrul, Dr. Iskandar Zulkarnain, Dr. Ismail, Dr. Iza. Is there anyone there that can help to present on your issue?
Hi, Dr. Farah. But
Hi, hello.
I cannot open the PDF. Can someone from the group
Oh, I
share
see.
the screen? Because I'm using a tab.
Oh, I see.
Yeah,
Would you be
so
able to share it in the chat box and
can
maybe I could
you,
try to present from there?
can one of the group share it from the, yes.
Okay, great.
All right, so we are from the group 2, we are actually, can you hear me well? Is it okay?
Oh, yes, can hear you loud and clear.
Yes, the code of conduct where we chose the topic educating patient on the GP fee schedule in Malaysia, which is quite a hot topic recently. So I'm Ismail, I'm from GP. So what we discussed was when we are educating the patient on the GP fee schedule, we are talking about the clear signage which is we have to show the patient how much is the consultation fees that we are providing in our clinic. So signage is compulsory, which is a rule from CCAPS before actually opening of any clinic. So we have to display a clear fee schedule for consultation and other services in the prominent location of the clinic, whether during waiting areas, over next to the receptions. And we have, during even the consultation itself, we have to actually explain to the patient what are the things that we need to do. So when patients are querying about the consultation fee, we have to explain how much the consultation fee, which excluding the possible other services like maybe pap smear, TNS, blood investigations. Um, uh, and then after that, even during the procedures that we are doing, let's say TNS, we have to provide the written informations and consent. So the patient will know that the procedures we are doing and also the possible fees that will be charged. Okay, addressing the patient concern regarding the scheduling fees of GPs in Malaysia, we would tell the patient as of now, this only been it's already not been mandated yet, but as our current fee schedule is currently is a certain, which is 10 to 30 ringgit. We have not changed any yet until the government allows us to do it. So when we are explaining to the patients also, if the fee increases, we would suggest to implement it gradually, not at a sudden surge. So it will, how to say, will be more comfortable for the patient. So gradually, will not be shocked with the new fee scheduling. Other than that, so in terms of fee, also we have also with government support, we have advocate also government assistance for vulnerable patients like Scheme Madani. We also have that program. Other than that, when the patient is actually inquiring about the value of care, we explain to the patients that the price of that consultation fee is actually professional qualifications, the service time that we are giving, and we are adherence to the clinical practice that been adhered to us. Even if the patient actually feels like dissatisfactions, so we always would say, I understand the possible concern. So let me walk you through what are the possible charges that we are going. So if you are not satisfied with our, still contemplating whether to come service with us, we can always suggest you to a place that you are comfortable with. Maybe we can refer you to clinic kesihatan and all. Other than that, when any procedures that we are giving, please have a written estimates for the procedures so that the patient will, so during payment time, they will aware that the possible how much they are spending money on. That's it.
Okay, great, great. Well done. I'm
Mm.
glad you picked this issue because this is the hot topic now
Mm.
in the last few weeks, isn't it? Yeah.
Yes.
And I'm sure there are a lot of GPs in our groups now. I think it's very difficult to do risk communication to patients who have been so used to very low charges. I agree with you guys. It's going to take a lot of risk com. Yeah, a lot of and some patients might be able to handle it, some might argue. Yeah, I think you have to be prepared for all sorts of reactions.
Yes,
um
doctor.
it probably helps not to look at social media all the time now, because some of the I mean, I have to say, even though I'm not a GP, but when I see the comments from the public, it can get quite disheartening. So yes, if you have your own usual patients and all that, it's nice to just maybe tell them a little bit about it, as they become more aware of the issue, and hopefully, if the fee schedule increases, then uh, the public will be more understanding of the GP's issues. Yeah. So great, well done with your group. How many GPs are in your group actually?
I think just the two of us. I think
Oh,
me
the two
and
of you guys.
doctor.
Okay,
Yeah,
I see. I
actually,
see. Yeah. Yeah, but that's good. That's good. It's good that we talk about these issues now. This is the only space to do it. Yeah. Okay. All right. Does anyone else have any comments about it? Because this is, I know, a very hot topic. Anybody else from other groups want to chip in something or give a comment? Feel free to, turn on your mics. Atau nak meluahkan perasaan ke?
Can I say something? Can
Sure,
I?
sure. Yeah.
Sure. I think even for our GPs, we actually got a few hot comments from our KKM counterparts. They were degrading us, saying that why we are making a lot of money, But as you can see, our cap for consultation fee has not been changed since 1992. But we can say that the prices of medications have been increasing even as of 15 of May. Even medical reps have informed us that there's going to be increase in price of medications. So we try to not to increase as much as possible because we are concerned of our patients, but at the same time, we are worried of our livelihood because things are getting expensive nowadays with so please be kind to us.
Yeah. Well, I mean, I want to like defend and say, like, not all government doctors think like that, lah. I mean, there are a lot of other KKM doctors who also they're sympathetic to the GP's plight as well. Yeah. Some of them are our good friends, like Dr. Paran, our good friends also are GPs. Yeah.
Yeah,
So
yeah, yeah.
yeah, isn't
Yeah.
it? Like, it's a shared environment, and we're all working towards the betterment of primary care. So yeah, we understand your concerns. We are also rooting for you guys, lah, in a way. Yeah.
Yes, yes. We totally support.
Okay. Yeah.
Yes.
Dr. Paran, you
Thank
marched
you.
that day, to Putrajaya.
Yeah.
You didn't march
Carry
that day
on.
to Putrajaya.
Oh no, I couldn't make it. I'm in Johor Bahru now. I wish I
Okay.
could.
Okay. All right. So well done to group 2. All right. So if you
Thank you,
don't mind,
doctor.
doctor, you can put your PDF in the chat box if you're able to. Yeah. Okay. So now we'll move on to group number 3. Yeah. Group number 3.
Good evening, Dr. Farah.
Hi. Good evening.
Hi, I'm Kitana here. We'll be sharing the screen in a bit. Okay.
Okay. Sure.
Our topic is how the doctor deals with issues dealing with medical informatics in practice. The aim is to assist the practitioners to gain sufficient knowledge and skills in electronic medical records. So, mainly we choose the part where we have to identify the shortcomings of the system actually. As we know, mainly GPs, I think Clinic Kesihatan also, I think they have this online medical information records, right? So for GPs also we have this, and there's a lot of shortcomings in the system actually, to be honest. So I will start on with the user burden. Okay, user burden, if let's say someone is very new to the setting, especially those clinicians who are like not in the same clinic, they are like doing locums elsewhere, they will have some of them will have difficulties to get familiarized with the system. Actually, certain clinics, they have different systems, so to in order to get to know that, it might be time consuming. This could be one of the shortcomings, doctor. And documentation wise, so when they are getting to know the system and when they document the records or patient records, this can disrupt the workflow actually, and it reduces the, what do you call that, contact time with the patient. So they don't have enough eye contact compared to where, especially when they're recording the medical information in the system. That part is for the user burden. And one more is the privacy and security issues, whereby hacking and data breach nowadays is very common, especially when everything's online, and it is very easily accessible, and it can be accessed by anyone, not only clinicians, even the clinic staffs, or like workers there, or even other doctors who comes to the clinic newly. They can literally can copy paste if they are breaching the data breach, or even the clinic what do you call that, in HR and all, they could what do you call that, get access to the system actually, and the PNC of the patient will not be well kept that time. That can be another shortcoming, doctor. And as for the cost, to maintain and to troubleshoot the system, the clinic system could be costly. So some clinics, they might have not don't have the updated version of the system. So in order to maintain that, they might need to spend some money to in order to keep the system well. And one more, limited staff IT training, whereby if there's new staffs coming in to the clinic, as in like they newly joined, they have to be taught on how to handle the electronics medical records, and that could be time consuming also, so they need support for that. And sometimes when they don't know a lot about it, they can cause errors as well. And also that if there's inadequate staffing, staff people, I mean staffs in the clinic, that could be another issue in the clinic. So there will be another thing is no standardized documentation or format, whereby each clinicians have their own way of recording the information from the patient when they come with a complaint. So some might use like short forms and all, and or they don't give proper explanation during the the documentation. So when the patient comes for a follow up, or to for the further management, it will be difficult for the next treating doctor. So the patient might need to repeat the same complaint again. That could be time consuming, and patient will not be happy about it. So that is one more, doctor. And poor connectivity. So when there is what do you call that, when we depend on like this online the system too much, when there's no connection and all, for them to go back to manual writing, there will be difficulty, because we can't access back to patients information or medication and all. So for that, they have to spend a bit more time to to get the information from the patients actually. And for this, there will be fragmented communication when they are concentrated too much on the system. While typing, there will be fragmented communication with the patients actually. I think that's about it, doctor.
Okay, great, great. I think you listed down everything about the disadvantages or the risk that can happen with an electronic medical system. I'm sure in certain KKM clinics and some GP clinics, they've already started EMR, so they would know the
Yeah.
disadvantages as the practice goes along. Yeah, I think especially in interior where there's no stable electricity or internet
Mhm.
connection. Yeah.
Yes.
All right. So great. Well done.
Thank you,
Group 3.
doctor.
Okay. Anyone else would like to comment on this, or any other disadvantages or shortcomings of EMR? I think this pretty much covers all the issues with it. Okay. All right.
Alright.
So if you don't mind, you just share your PDF, your file into the chat box. Okay. Okay. So now we move on to group number 4. All right. May I have the representative from group 4?
Hi, Dr. Farah. Good evening.
Hi, doctor. Hi.
Right. Let me share my screen first.
Okay, sure.
All right. It's connecting. Sorry, doctor, for the delay.
No, it's all right. It's all right. Maybe just to get the ball rolling, I'll just talk. What was your group's question about medical practice and about starting up a GP clinic? How to manage the setting up?
Yes, doctor.
Which issue do you guys choose?
So we are choosing the 7th.
Number 7.
Yeah, number
Okay.
7th issue.
Okay,
So,
to determine the level of care. Is that right?
yes.
Okay, great. So, like when you're setting up a GP clinic, what is the care that you would want to administer to set up? Is that right?
Yes.
Okay, great.
All right.
Okay.
Trying to share. Are you guys seeing my screening now?
Small. Could you please just large? Yeah. Okay.
All right.
Okay.
Okay. Yeah. So for group number 4, should I read from the first?
No, you can just go straight into your issue. It's fine.
Okay, so our issue is to determine the level of care to be given in primary care setting or in clinic setting. So from our group discussion, we would divide the standard of level of our care covering primary and secondary prevention. So under our primary prevention, we would cover on vaccination, which includes childhood schedule, and adult boosters dose for vaccination, and also including elderly, general health screening, assessing risks that patient has through ECGs, chest X-ray, urine tests, FBCs, based on their underlying illness, the risk factors from family histories, and further history taking. And another one is health talk. We some private GPs go for a health talk in certain companies and school, providing awareness on vaccination, advice on therapeutic lifestyle changes, awareness on risk of smoking or vaping. Under secondary prevention, we will provide pre-pregnancy care, whereby we provide folic acid prior pregnancy, ensure safe medications once patient is pregnant. Means that if we start patient which has underlying chronic illness, we will ensure that the patient knows that all these medications is not safe once they are pregnant. So we ensure the patient will come to us immediately once they are pregnant. Ensure good control of NCD disease. So also chronic diseases for male patient in general, managing the diabetes, hypertension, thyroid disease, etc. Cancer screening based on risk, involving pap smear, IFOP test, or even we would, if there is a radiologist available, we would do ultrasound, breast ultrasound on patients. Mammogram, maybe we would suggest them to go to centers that provide breast cancer screening. There is one besides HKL. I couldn't remember the building name. Okay. Women health, we will provide contraceptive devices such as Implanon, IUCD, HPV vaccination, provide education on menstruation cycle and menopausal, perimenopausal syndrome, what would they need to do, what are the available treatments can be given, such as hormonal therapy, men's health, including BPH and ED, erectile dysfunction, wound dressing for diabetic patients, venous arterial ulcers included, mental health, counseling. We could provide counseling, and also screening for through Woolly score, GAD, PHQ-9, STD screening included. So that's about it.
Okay, great. I think your group has done very well because this ties in with what Dr. Paran talked about in his lecture about prevention. And yes, a large bulk of our work is preventing things from getting worse, right?
Yes,
just a comment, where does acute care fit into all this? Like say emergency, like minor emergencies or, um,
I think that would
probably
fall
doesn't.
under secondary prevention.
Okay, probably, yeah. But yeah, that's because when you talk about level of care, like what are the services that you would want to set up in your GP practice? So yeah, these are the things that you'd want to think about. So, but yes, this is a very good way of wanting to provide primary care. This is what we're supposed to be all about, lah. Yeah. Okay.
Okay, Doctor.
Or anyone has any other comments about this? No. Okay, I think if not, yeah, we'll applaud group 4. They've done quite well. Okay, so then we'll move on to group number 5. Yeah.
Hi, good evening, Dr. Farah and Dr.
Hi,
Pong.
hello. Okay.
Here, I'll be presenting on for group 5.
Okay, sure, go ahead.
Can you all see my slide? Can you all see my slide?
Yes, able to see.
Okay, so for our group, we will be presenting on the topics, the challenge that doctors face in prescribing, dispensing, and referrals. So we use the number 8 topic, which is methods to minimize medicine. So we divide into a few important points, which included medication action plan. So we can see from this chart, we divide into the two parts. First, assessment of medication itself and assessment of the patient. So under the assessment of medication, we have to assess indication of the medication itself, and then benefit, risk, and side effect of the patient to the patient, and then as well as identify high risk therapy and reconsider to discontinue or continue the medication, and then assess the drug interaction, such as interaction between warfarin and fluconazole, for example, will increase the bleeding. So this one we can check the drug to drug interaction via into the checker. So we have to, so we can make sure that we prescribe the right medication to the patient. And then for assessment of the patient itself, we have to make sure patient know that the goals of the care, and we have to adjust medication accordingly based on the patient condition ideas, concern, expectation. And then we have to identify the functional status of patient. Let's say in geriatric patient, we have to know the limitation, who is the caretaker for them, so to avoid any medication error or overdose in future. And then we have to adjust the medication based on the um, indication and to avoid the any unnecessary toxicity in future. And then the most important in medication prescribing to patient is assess adherence and barrier, to make sure that patient actually consume the medication that we prescribe, and then we should result in the good adherence and good outcomes in patient's treatment. And then the second point is we can use the clinical screening tools such as stop or start and various criteria. So we can see from here, usually we use this criteria for elderly patient. And then for the stop and start, usually we aim to prescribe the right medication to the patient and then to de-prescribing the inappropriate medication to the patient. And then for base criteria, what I found is more to we assess the appropriateness of the drug, such as like usually a jelly patient come to our clinic for laxative, gastric medication such as syrup MMT, and then so we have to actually revise back the medication and discontinue accordingly if they don't have the symptom and the symptom. So the next point is patient education on the indication, benefit and side effect of the medication. So in this case for PITS group and Jerry, we basically will counsel the patient regarding the medication together with the caretaker. So to make sure that we give the medication correctly and then assess the best response from patient. So the second last point is regular medication review by attending doctor. We can use the medication appropriateness index, which is available from the link attached. So this is the list of the questionnaire that we can assess to determine the appropriateness of the medication. So we can go through the list here, like indication for the drug, medication effective for the condition or not, is the dosage correct, are the direction correct, and is it practical for the patient, and then is there any clinically significant drug interaction, is there any unnecessary duplication of the other drugs, such as we give multiple antihypertensive to the geriatric groups will cause unnecessary hypotension episode. And then we have to know, we have to pay attention as well to the cost effective in terms of cost of the drugs nowadays, which one is the most cost effective for the drugs, for the patient's drug. And for the last one is under topic D, prescribing, we have to identify and prioritize medication to the discontinue and discuss the potential prescribing with the patient, as well as example antihistamine and sedative. So basically that's all for our group.
Okay, great. Well done. This is very, very complete. So well done to your group. I don't think I need to add in anything else. Anyone else has any comments about polymedicine? I'm glad nobody brought up about fixed dose combinations. Because always in especially for in what do you call it, private settings, they always push for fixed dose combinations as a first line, even if they might not need it. So always look at the appropriateness of every medication. Do they really need to be on it, and what is the cost implication for the patient as well? Anybody else has any comments about that? Okay, if not, okay, thank you very much. Just to remind, you can put your PDF or your presentation into the chat box for everyone to learn from as well. Okay. Okay, so now we'll move on to the next group. Group number 6. About workplace fitness. Yeah. Group number 6. Do you have a representative?
Yes, Doctor, I'm here.
Hi, Doctor. Hi. Yeah. Okay, you can carry on.
Just open another sharing screen. Okay, my topic was what are the challenges doctors encounter when giving health certification or workplace certification for a patient. So when we decided to review on the patient's agenda. So our main an approach to this question was exploring the idea, concern, and expectations of patients. So first, can can you see, Doctor?
Yes, able to see.
All right. So concerns when the patient are coming to us. First one is like example would be some patients might not disclose why they want an MC or sick leave or something. So they might have workplace stress or interpersonal conflicts with the person at home or at work. And also they can't even get a day of rest. Example, they might need an MC, if not their salary might be cut. So these are when they are coming to us with hidden agendas. So the doctors will face the challenges that we face is to read between the lines why they are asking and to actually undercover like why they are coming seeking the health sick leave. So explore more on the psychosocial issues and counsel them more on that. Second one is the conflict that doctors face. It's the conflict between patient expectation and medical evidence. Example, the patient might just complain that they feel physically or mentally tired and they're requesting time off. Or example, disability support, they might bring a letter for a chronic back pain or something like that, on workplace adjustment. Which will be based on how they feel, and we don't have any evidence or clinical findings to support their health certificate. So when what we face is when we have subjective symptoms, yes, it is not. We have to explore further on that before giving them the certification. Uh, the third part is assessing their psychosocial mental health complexity. This one surrounds their stress, anxiety, burnout at work. So we have to, it is quite difficult to verify this condition. They might say, oh, I'm stressed at work. So it is actually a bit hard to be able to verify that condition. The next one is the pressure that we face to support certification, because if we don't give MC nowadays, we are getting CISPAR, and also we have to balance it in actually finding what is wrong with the patient, their patient's need, and actually whether the patient is actually ill before giving out it's our professional responsibility before we are giving ethical certificate for them. Last one is this one may be more on a private setting. It risks damaging the doctor and patient trust when the patient goes to them and saying, I'm well, I need a sick leave, but when we do not find the evidence of behind it and whether we want to keep the MC, if we don't give, the patient might not return back to us. So these are the challenges when we face when we are giving sick leave to the patient.
Okay, great. Would anyone like to comment or give any experiences that you've encountered with this, especially when giving MCs? Like how you brought up the issue of takut kena CISPA. It's always a concern, isn't it, for the doctors in government? But yes, always have to address the patient's concerns and expectations. Correct. Yeah. Um, let's see. Anyone have any comments about this? No, if not, we'll move on to the next group in the interest of time, because we only have about 15 minutes left. Oh, someone commented chat box, verbal fight if no MC. Yes, sometimes if the patients are, at a high temperament, they might, they might have some um, nasty words, maybe. Um, another one. Patient refused to leave the consultation room if no MC given. So yes, it's difficult to approach. Yes, but again, it all comes down to addressing the concerns and expectations of the patient. And yes, that needs to the issue has to be spent a little more time to see what is their understanding of it. How do we get them to come to terms with our diagnosis, or whether we are going to give an MC or not. It might make things a bit easier if you spend a little bit more time with the patient and explain things calmly to them. Yeah? And then this becomes a difficult consultation pula, the angry patient pula. Okay. All right. And okay. There's a comment. Sorry, a question in the chat box. How to deal with parents who also ask for MC to look after their sick child? So again, you have to explore what is the ideas about an MC. What is an MC for? Who is given for, and all that. So you still have to listen to what they think that it is, and then explain to them what it actually is for. MC is only for the patient, not for carers, caregivers, and all that. Yeah. So it's a legal document. You have to explain a little bit about it. But yeah, it's always in the manner in which you explain things to the patients. If let's say it's something that's infectious disease that related, let's say hand, foot, and mouth, and all that, they might be eligible for duty quarantine, for example. So it's a slightly different MC. But for things that don't fall under the quarantine leave or anything, that's when you have to use your your communication skills to bargain with the patient. Um, and basically, the bottom line is that you can't give an MC for them for this sort of reason. Okay. All right. There's another comment. Sometimes they said it's budi bicara. No, it all boils down to the legality of the document. You can't give an MC to someone who's not sick, so that's not ethical. Yeah. So that it boils down to that. Yeah, extension of quarantine leave versus taking annual leave dilemma. Yeah, that is a dilemma which you have to slow talk them into agreeing that it you know uh how long that the infectiousness is going to last and all that, and that's why the quarantine leave is uh, given as such. Okay. Oh, this one. Certain patients feel entitled to have MC because they pay in private practice. Again, it's all in your communication skills to tell them no, that's not really true. You are paying for the consultation, not for the MC, automatic MC. Okay. Um, all right. Anybody else has any comments or questions about this? Dr. Paran, any comments? Because this is always a hot topic. Give MC, not give MC.
Yeah, it's always an issue there. But I think the other point I want to mention is for doctors to document whatever the consultation went on and all that, because sometimes when there are complaints or issues, the weakness on our side is poor documentation. So we are not able to defend ourselves. That's part doctors that I mentioned now. So, yeah. Okay.
Thanks, Doctor.
All right.
Okay. All right. If there are no other comments, we'll move on to the next group because we have two more groups to go. All right. Thanks, Doctor. You can put your presentation in the chat box as well. Okay. All right. Now moving on to the next group. Group 7. If I'm not mistaken. Group 7. Okay. You can present your discussion. Sorry. Is there any representative from Group 7?
Hello. Hi, doctor.
Hi, hello.
I
Yeah, you
I'm
can carry on.
my name is Ruben and I'm from the GP sector. Okay. So we are from group 7 and ours is activity 7, quality and safety. So ours is more of a challenges of quality and safety in family medicine, and we chose the outcome number 1, which is to list the reasons for carrying out audits in the clinic. So, audits in the clinic and any family medicine clinic is actually mainly is done for quality assurance, and it actually we do it so that we can identify where are the weaknesses, and then we can also see what's the progress in our clinic, and also to improve the clinical outcomes, also mainly for the patients. So our issues over here, so the mainly that we do is because some of the challenges that are being faced by patients, so which is improving patient care or mismanagement of the patients. So um, this happens when some of the uh, actually it's all connected mainly, but okay. So the reason why we want to do audits to actually to settle for this kind of challenges is mainly to ensure the patient safety, and for us to improve the patient care, and also to ensure that we have evidence-based practice which is being followed, and also to ensure that the clinical practices is obeying the protocols and also the standard. And at the same time, we also have challenge. One of the challenges because of incomplete data. So incomplete data could be due to medical records, mainly because some clinics I don't think most of the clinics nowadays are already using computerized systems, and also in Malaysia our computerized systems, they are not connected everywhere. So a lot of it's not integrated, so a lot of places they are using different especially GP clinics and hospitals, they're using different systems. So every patient's records will not be connected at one particular hospital, one particular system. So this will cause a lot of issues in between. So then after that, and then we also have, so the reason we do audit for that is because we want to maintain accurate and continuation of medical records for the patient. The next one will be due to the challenges that we will have is due to a lack of trained staffs. So trained staffs meaning we have staffs who are coming in, the fresh staff who are coming in, and also some of the staff who probably has gone for the course for for a long time ago, and probably they would have forgotten their whatever that they have learned. So over here, what are the reasons that we do is because we wanted to identify and train the staff for proper practices, not just that for the new staff who just joined in, like for an example, if let's just say that particular staff has gone to a KK which has a palliative practice, and that particular staff doesn't know much about the palliative, I'm talking mainly about nurses, so they will need to go for courses, CMEs and courses, and also some of them who has already gone but they have already forgotten what they have studied, then this will be more of like a revision so that they can improve their knowledge. So this is another one more thing. And one more challenge that mainly that we will face in public healthcare setting is mainly workload, time constraint, and lack of staff. So this eventually will lead to mismanagement of patients again. So what happens is, because if let's just say we don't have like earlier we discussed in the group, if we don't have a proper triaging system and we don't have enough staff, so what happens? Some of the patients, they don't know what they have. Some of the doctors in rural areas, the patients may not know what they have, and they may just come in and sit over there when they have like a very contagious disease, and for an example like monkeypox. So patient may not know what they have, they just come in and they just register, and they just come and sit down and they just say they probably will have fever, and then they wait for about 2 hours before being called to the doctor's room, and by then they have already spread the infection to the people who are also waiting at the same time. So if we have enough staff, and then if we have uh, like triaging system, so that will actually in the beginning itself, so that will actually help to identify and to segregate patients like this. So that all comes down to because of workload. And then time constraint is mainly for some patients, In GP setting, it's okay, but in clinic KK settings, because there are too many patients and we don't have as many doctors, so the time being spent for every patient is all limited. So we are not really able to go all the way down and deep into like what are they actually having to do a proper full examination. And then also sometimes psychiatric patients will take a lot of time. They might just break down and start crying, and we won't have enough time. So this will actually cause a lot of issues. So that is why the audits that we do is mainly to identify these are the challenges, and also to make sure that uh, patient safety and also improving patient care will be our utmost priority.
Okay, great, great. I think that's pretty much all the points that that should be brought up for this issue. I think what you mentioned about was patient safety. I think that would be the main aim, right, for audits,
Yes,
and how we can improve that either the work process or the resources to get to that aim of patient safety. Yeah?
And also, doctor, actually, it's not just patient safety, it's also staff safety at the same time.
Yeah, of course, yeah.
Yeah, so that's why it's overall ensuring that the whole entire system, everyone is being taken care of.
Okay. Okay, great. I think well done. Your group's done very well, actually. Yeah.
Thank you.
So if you don't mind, you can share your file into the chat box. And then for group 6 just now, would you mind also sharing your file into the chat box as well, so that other people can learn from the issues as well? Yeah. Okay. All right. So now we'll move on to the next group. Group number 8. So this is the last group, I believe. Yeah.
Hello,
May
hi,
I have
Doctor.
any?
Yes,
Okay. Hi. Hello. Yeah.
Dr. Tanvir here.
Okay.
I'm from GP as well. So, wait, just let me share my screen first. Okay, wait. Can everyone see the?
Yes, yes, we're able to see. Yeah.
Yeah. So, actually, our topic was more onto the Private Healthcare Facilities and Services Act 1998. So we chose question number 8 in correlation to our group number as well. All the fines that could be imposed if you breach any of the acts. So for those who are in GP, I'm sure that everyone is familiar with the current issue where we have to display all the drug prices, right? So based on what we have searched, it seems that the facilities can be fined up to 100,000 for not displaying medication prices as required. And there is additional fines that can be imposed for each day if the offense continues after conviction. And there is also penalties for non-compliance, meaning that after they have fined you for not showing the act, and if you still didn't comply and do it, then you can be fined. For those who are running individual clinics, you can be fined up to 300,000 or imprisonment for up to 6 years. I feel it's a little bit harsh, but that's what they have decided. And for corporations, partnerships, you can be fined up to 500,000 with additional daily fines for continuing the offenses. And the additional daily fines varies. It can be from 1,000 to 5,000 each day. Yeah? And next is like failure to comply with service standards, meaning not meeting prescribed standards for services, infrastructure, or staffing. You can be fined up to 50,000 ringgit. Quite important, I was not aware of this, but non-consensual treatment, failing to obtain informed consent before treatment, you can be fined up to 30,000 ringgit. And employing of unqualified personnel, such as hiring healthcare personnel without proper qualifications, certifications, APC, or anything that is done in a very dodgy manner, you can be fined up to 30,000 ringgit. And we have a few other summaries of the fines under the Private Healthcare Facilities and Services Act. Operating without a license, for those individual clinics, you can be fined up to 300,000, 6-year jail, or 1,000 per day for continuing the offenses. And for those who are running in a corporate clinic, you can be fined up to 500,000, 5,000 per day for continuing the offenses. Non-compliance by licensee, meaning not fulfilling the requirements set by the Act. For individual clinics, you can be fined up to 100,000 fine, 2 years jail, and for those in the corporates, you can be fined up to 300,000. Misusing of your licensed premises, such as applying for one but doing on another act, you can be fined up to 300,000 daily fines for continued breach. And breach of closure, this is what they meant on this is that there is a few certain SOP steps that you have to take when you plan to actually close down your clinic, such as like informing the government, knowing how to discard your patients' records safely without being leaked out, and failure to comply with those SOPs, you can be fined up to 100,000, jail up to a year. Daily fines do apply, and for other offenses, fines up to 300,000 and/or imprisonment. Quite interesting for this as well. There's an act, failure to discuss charges with patients, which is a lot of times we do come across, doctor don't inform usually, all right? But failure to discuss charges prior to treatment, you can be fined up to 10,000 ringgit, imprisonment up to 3 months or both. Failure to control infection, you can be fined up to 10,000, imprisonment up to 3 months or both as well. And under section 84, section of the Act, a licensee refuses or fails to furnish the information required or furnishing false or misleading information, you can be fined up to 10,000 ringgit, not exceeding 3 months or both. And for those in the corporate, you can be fined not exceeding more than 50,000 ringgit. And as stated over here, misleading advertisement under the Private Healthcare Facilities and Services Act, you can be fined up to 10,000 ringgit, imprisonment up to 3 months, or could be both as well. Thank you, Doctor.
Okay, great. Okay, you've listed out all the important fines. Actually, the part about the advertising, that's very interesting because you do get a lot of social media advertisements nowadays, right?
Yes.
And when they advertise their services, something, yeah. So if you choose to do so, you have to be really careful about what you really put, the information that you put up in a social media post, because someone could turn around and say it's misleading or something, you know.
Yep.
So I think in this modern era where we use a lot of AI and all that to generate all these advertisements, you have to be really careful about, especially social media, lah. Yeah.
Yes. In fact, like I'm
Yeah.
actually in the midst of setting up my own clinic as well, Doctor. So
Okay.
the whole process of application, the part that they were quite strict and they were very, how do I say, like detailed, precise, was the part where I had to submit to them what are the list of services that I was going to carry out at the clinic. Yeah, so I had issues on that basis, so it's like a lot. So yeah, I mean they're quite strict, but yeah.
Yeah. I think that's not the only thing that's strict about, isn't it?
Oh
There's
yeah,
a
I
lot of
mean
other things as well.
it's a whole
Yeah.
it's a big headache, to be honest, with the way their rulings are at the moment. But
Yeah.
I mean, I think it's for the betterment of everyone, I guess.
Yeah.
Yeah.
Okay. All right. Anyone else has any comments about this? Or want to ask anything about kena bayar saman? Okay, I think it's quite clear because all these fines, it's to hinder, what do you call it, malpractice or poor practices in the clinic setting, lah. It's a deterrent. Yeah. Okay. All right. Now, would you mind sharing the file also in the
Right.
chat box?
Will do, Doctor. Thank you.
Okay, great. Okay. So I think all the groups have done very well. You see, compared to the previous groups that I've done over the years, some of them took a lot longer to discuss the issues and come up with points. So I'm very glad everyone did the discussion very thoroughly and very well. Yeah. Dr. Pan, would you like to add anything else?
Yeah, I think they did very well. This group, they are very proactive. I agree with you, Farah. I think the current intake, they're up and about, the leaps above from the previous one. They are quite well prepared and quite proactive. So I'm glad to see the level of participation and interactive, aspect of this group, right? So good. I think we had a very good afternoon. I hope everybody learned what we are supposed to learn on this module, lah, at least you have a take home messages and info and all this. Right. Yeah, that's about it. Yeah. And thank you, Farah, for facilitating the
You're
second half
welcome.
of it.
Yeah.
Very well done.
Okay.
Right.
So
Right.
yeah, I'd just like to let everyone know, like, all the issues that have been, the questions that are listed out in each activity. Actually, you can go through all the others and see, because these are very pertinent issues to when you're practicing either in the government side or the private practice side. And it's good to know about both worlds as well. Yeah. Okay. All right. Any last comments or questions? Okay, I think most of the groups have sent in their files. They're just waiting for group 8 only lah to share the file in the chat box. But any last words, Dr. Parit?
I think that's about it. So I wish all the best for this group for their exams and coming what do you call it, tests. When is that? I think there's sometime in September, is it? I can't remember. Yeah. So wish you all the best. And I think their
Next year,
assignments
May
already been
2026.
handed in. So I think we will start marking on that. Yeah. Right.
Okay, sure. Okay, I think yeah, I've got all the files already, Doctor. Okay, so any last comments, you can always ask us. Yeah. And I think all the activity files and all the group work has been posted in the chat box, so you guys can have a read through it when you guys are free lah. Okay, all right. So everyone enjoy the rest of your weekend. Okay, hope to see you again soon.
Let's have a group photo.
Group photo. Oh, okay. Yeah. How do we go about it? Everybody has to turn on their camera, is it?
Yeah, I turn on the camera, then we do a screenshot. Yeah.
Okay. The screenshot. Okay, maybe I could try to do that. Hold on.
So
Okay,
everyone turn on the
yeah.
cameras.
So I will try to hold on. Let me try to do the gallery view. Okay, so I will need to take screenshot 3 times because in my screen there's like 3 groups, three
Okay.
pages. So I'll just screenshot one at a time first. Okay, all right. So because you wouldn't know which group you're in, so you just have to smile. Okay, when I say 1, 2, 3, smile. Okay, so all right, 1, 2, 3, smile. Okay, wait. There's some who haven't turned on their cameras yet. I see, man. Hold on. Okay, 1, 2, 3, smile. Okay, hold on. So, moment. Okay, all right, next group. Okay, all right, everybody smile. 1, 2, 3, smile. Okay, just hold on a second. Okay, then the final one. Okay. Right. 1, 2, 3, smile. Okay. Okay, I think I've got everything. Okay, all right, Dr. Pan. All right, got all the screenshots. Okay. Okay, you all can turn off your screens now. I know everyone has their cat, dog, and baby on board as well. My cats are in the background actually, so luckily you didn't see them jumping. Okay, Dr. Pan, anything else to give a message on? Dr. Pan pun dah keluar. Oh. Okay, so I think everyone can exit the group already lah, the meeting. All right, thanks and have a good weekend.
Thank you. Bye bye, everyone. Thank you. Bye all. Happy weekend.